Welcome to part one of our three-part webinar series on HPV in women. To receive continuing education credit for this activity, you must take the pre and post test. If you have not taken the pre and post test, you are viewing this webinar live, you will find the pre-test link in your reminder email, and the post-test link will be sent to you after the webinar. If you are viewing this webinar on demand, both the pre and post-test links can be found below this video. In the webinar dashboard, you should see a chat box that you can use to answer questions throughout the webinar, which our faculty will answer at the end of the webinar. In 4 weeks, you will receive an email from ARHP's Education Department with a link to a follow-up evaluation. We ask that you complete this evaluation to let us know how you have incorporated what you have learned during this webinar into your work. Completing the pre and post test as well as the follow-up evaluation helps ARHP ensure we continue to meet your educational needs and interests. Thank you in advance for your time and feedback. At this time, I would like to introduce our faculty, Dr. Aletha Akers. Dr. Aletha Akers is a faculty member at Policy Lab at the Children's Hospital of Philadelphia and an adolescent gynecologist and medical director of adolescent gynecology consultative services in the Craig Dulcimer Division of Adolescent Medicine at the Children's Hospital of Philadelphia. Dr. Akers is an expert in pediatric and adolescent gynecology. She provides clinical care to children, adolescents, and young women with complex gynecologic care needs. She has expertise in providing routine preventative care and addressing the contraception needs of adolescents with medical problems and those at risk of unplanned pregnancy. Dr. Akers also has experience developing and evaluating public health programs and health services interventions to improve adolescent and young adult health in both academic and community settings. Her research focuses on improving reproductive health outcomes among adolescent women by reducing teen pregnancy and sexually transmitted infection rates by increasing adolescent access to high-quality reproductive health services. We're thrilled to have her with us today, and without further ado, I'll hand it over to Dr. Akers.
Thank you so much for that introduction, and thank you to all of you who've joined our webinar. We will be speaking for about the next hour. We will leave time for questions at the end, so please, if you have any, write them down or log them into our box. And with that, I will get started. So we'll be speaking today about HPV in women. We do have several other webinars that will be coming in the near future, as mentioned, and we'll have a listing of those at the end. For my assistance on the call, our slides are not advancing. Perfect. Do I have control now?
Yes,
I do.
you do have.
Great, thank you. So this webinar series was made possible by an independent grant through the Merck Corporation. I have several disclosures that I would like to make today. I am the recipient of an investigator-initiated grant from Bayer Healthcare. I also serve on the HPV Advisory Board for Merck and also have funding through the Templeton Foundation. So our learning objectives today are as followed. By the end of this presentation, you should be able to discuss the burden of HPV infections in women, paying special attention to HPV as viewed through the lens of intersectionality, where intersectionality is the way in which gender, race, and other social identities affect life, as well as health-related conditions like HPV in individuals. You should also be able to describe the relationship between HPV and cancer and how that relationship is modulated in women. You should be able to counsel patients on updated cervical cancer screening guidelines in women, including trans men who have a cervix. You should be able to address barriers to implementation of the HPV vaccine in current clinical practices, including education, access, consent to care, confidentiality, and administrative issues, as well as apply techniques and tips to counsel patients on updated HPV screening guidelines and preventative measures. I'd like to start our discussion today with a case, and that is of Janelle, who's a 19-year-old Caucasian female who presents for the first time to a university clinic for women's health to discuss her desire to switch from an oral contraceptive pill to the intrauterine device. Her medical history is unremarkable, and she's unsure whether she is up to date with her HPV vaccine, and she therefore left the immunization history section blank. So the key questions that I'd like for you all to consider today as we move through the rest of this webinar are, what are the critical questions you should ask Janelle as part of her medical and sexual history taking, as well as how would you proceed with clarifying her vaccination status, and if she needs to catch up on her doses of vaccine, what would you recommend? By the time we come to the end of this webinar, you should be able to answer these questions, and we'll return to these questions at the end. What I'd like to do now is move into talking about HPV in general, and then we'll look more specifically at issues related to women. In terms of HPV epidemiology, this slide summarizes the key things that we know as of 2017. HPV is the most common sexually transmitted infection in the United States, with nearly all sexually active people acquiring HPV at some point in their lives. According to data from the Centers for Disease Control, approximately 79 million Americans are currently infected with HPV, and approximately 14 million people become newly infected each year. It should be noted that these numbers are estimates that come from the pre-vaccine era, the pre-HPV vaccine era, with the current incidence and prevalence much likely being lower in the 11 years since the HPV vaccines were introduced. And this is particularly true among individuals who are currently under the age of 25. Such individuals are those in whom new HPV infections occur most commonly. What we do know in terms of more recent data that provide us guidance regarding what the current prevalence data are, these data come from the National Health and Nutrition Examination Survey, or NHANES, and show that the prevalence of any genital HPV infection was approximately 42.5% among adults between the ages of 18 and 59, and that comes from NHANES data from 2013 and 2014. That wave of the NHANES survey also demonstrated that 80% of sexually active women are infected with HPV by the age of 50, and an estimated 17,600 women and 9,300 men are diagnosed with an HPV-related cancer each year in the United States. Regarding HPV transmission, sexual intercourse is the primary route of transmission. HPV is transmitted via direct genital contact as opposed to through body fluids like most sexually transmitted infections. Receptive anal intercourse is strongly associated with HPV infection, with studies among men who have sex with men and have anal intercourse demonstrating that 61% of those who are HIV negative and 93% of those who are HIV positive currently having HPV infection. Genital contact in the absence of intercourse is a plausible means for HPV transmission, but the risk associated with this contact is thought to be much lower than that for penile-vaginal intercourse. The virus can also be transmitted via oral genital contact. HPV is not thought to survive for very long on inanimate objects. However, it is possible that transmission could occur through objects that may be shared in the short term, such as via insertive sex toys. This slide lists some of the biologically and behaviorally based risk factors that have been found to be associated with HPV. Key biologically based risk factors, as you can see on the left side of the slide, include both host factors and viral factors. Some key host factors are things like age at first menarche and age at sexual debut, along with co-infection with other sexually transmitted infections. Key viral factors include the type of HPV an individual is infected with, and there are more than 120 known types of the HPV virus. Biologically based risk factors primarily affect downstream transitions in the oncogenesis pathway rather than the risk for acquiring HPV, and include characteristics that may be of the virus itself or intrinsic host factors that may affect immune response, such as those items listed again on the left. Behaviorally based risk factors primarily affect the acquisition of the HPV infection and are logical factors to consider in risk-based HPV vaccination strategies. And those are listed on the right side of the slide. And you can see these are divided into sexual history-related factors, such as lifetime number of sex partners, having a recent new partner or an older sex partner, as well as substance use-related factors, such as heavy alcohol use. HPV-associated clinical conditions are listed here and can include genital warts or cervical cancer, with genital warts potentially appearing in any of the sites listed here, including in the vulvovaginal or anogenital area for females and males respectively, around the anus, as well as in the mouth or throat. One of the most morbid health conditions that can result from HPV infection is cancer, of which there are many types. To assess the incidence of HPV-associated cancers, the Centers for Disease Control analyzed high-quality data from the CDC's National Program of Cancer Registries and the National Cancer Institute's Surveillance, Epidemiologic, and End Results, or SEER program. During the period between 2008 and 2012, an average of approximately 38,800 HPV-associated cancers were diagnosed each year, including about 23,000 among females and 15,800 among males, that corresponding to about 60% of these occurring in females and about 41% in males. By multiplying these counts by the percentages attributable to HPV, the CDC was able to estimate that approximately 31,000 new cancers were thought to be attributable to HPV infection, including about 19,000 among females and about 12,000 among males. Of the approximately 39,000 cancers that occurred each year in the United States at anatomical sites associated with HPV, about 30,700 can be attributable to HPV, with 28,500 attributable to high-risk HPV types that are included and therefore covered by the 9-valent HPV vaccine. This slide shows the estimated proportion of cancers that are attributable to HPV in the U.S. and shows the type of cancer based on anatomical site, the proportion thought to be attributable to HPV, and then the last two columns show the proportions that are attributable to HPV type 16-18, which are the two most oncogenic types, as well as to HPV types 31, 33, 45, 52, and 58, which are also covered in the 9-valent HPV vaccine. The Centers for Disease Control and Prevention partnered with 7 U.S. population-based cancer registries to obtain archival tissue for cancers that had been diagnosed between the years 1993 to 2005, and HPV testing was performed on approximately 3,000 case patients that were fairly representative of all participating cancer registry cases by age and sex. They were able to obtain demographical and clinical data and evaluated that based on each of the sites listed above and by HPV status. And as shown in this table, HPV detection was highest for cervical, anal, and vaginal cancers. And among the head and neck cancers, HPV detection was the highest for oropharyngeal cancers, as shown here. The attribution of HPV 16 and 18 was highest for anal cancer, cervical cancer, and oropharyngeal cancer. And looking at this last column, the attribution of these other 5 HPV types, which are in the 9-valent vaccine, was highest, as you can see, across a much wider range of anatomical sites. So I want to return now to this issue of intersectionality and the HPV vaccine. Intersectionality, as I mentioned earlier, is an approach that addresses the way gender and other social identities affect life and refers to mutually constitutive relationships that may influence one another. An intersectionality approach is based on social justice and aims to address issues of marginalized groups, such as sexual and gender minorities, by looking at the process of inclusion and exclusion, in this case, in either healthcare service access or delivery. This approach helps to explain how a single focus on either gender or race or any other socially constructed factor on its own may make it impossible to examine the manner in which social forces and locations interact and relate to one another in order to give shape to really the unique mosaic of human experiences, including healthcare experiences. If HPV is viewed through a lens of intersectionality, then more attention should be paid to not only how issues like gender or race may impact the incidence rates and vaccine policies, but also how other things like sexual orientation, race, socioeconomic status really combine to influence key factors like HPV knowledge, vaccination, detection of HPV, and incidence of HPV-related cancers. Much more really needs to be known about how these different layers of identity really impact HPV screening or vaccination rates and therefore downstream cancer rates. So throughout this talk, we're going to focus more specifically on looking at issues of race and sexual orientation because there's been emerging data that really demonstrates that race and ethnicity continue to be key factors driving disparities in both HPV disease and access to care. And there's increasing data demonstrating that for sexual minority individuals, the same appears to be true. So let's turn our attention now to talk more specifically about HPV in females. HPV infections most commonly affect women who are under the age of 25. Like males, females become infected with HPV by having sex with someone who is also infected with the virus. According to data from INHAMES, the overall HPV prevalence in the United States was approximately 27% among U.S. females between the ages of 14 and 59. It was 25% among those ages 14 to 19, and approximately 45% among women ages 20 to 24. So you can see that there are significant variations by age. In females, genital warts most often appear on the vulva and on the cervix, or in and around the vagina, the anus, the mouth, or throat. Virtually all cases of cervical cancer are caused by HPV, with just 2 types, 16 and 18, being responsible for about 70% of cases. Risk factors for genital HPV in women include being younger than age 25, as well as initiating sex prior to the age of 16, having many sex partners, or having a partner who has many partners. Let's talk about current screening recommendations and the rationale for these. Screening recommendations have been changing rapidly over the past decade, and so I want to review these briefly. But first, I want to start with talking about the goals of screening. It's important to recognize that cervical cancer screening involves both benefits as well as potential harms. It's also important to remember that the overall goal of cervical cancer screening is to prevent morbidity and mortality from cervical cancer. To achieve this goal, while balancing the benefits and potential harms of screening, we need to keep in mind several key, more specific goals. One, to identify and treat high-grade cervical cancer precursors. Two, to avoid unnecessary evaluations and harmful treatment. And three, to minimize the overall costs within the healthcare system. This slide reinforces these goals by highlighting that protection from cervical cancer is the primary goal of screening, but as the prevalence of this disease decreases with increasing use of the HPV vaccine, we need to remember that other considerations are also important in the decision-making process. For example, the effects of invasive diagnostic workups such as colposcopies and biopsies, as well as over-treatment of HPV lesions that are likely to regress, which is what can occur in much younger adolescent and young adult women, may have adverse consequences related not only to costs, but also to potential reproductive outcomes. Additionally, the anxiety and stigma that are associated with HPV infection and treatment can be significant concerns for women who participate in cervical cancer screening programs. The current cervical cancer screening recommendations are shown in this slide and are separated based on population and population by age, as well as based on other clinical statuses, such as whether a woman has undergone a hysterectomy and whether they've been vaccinated against HPV. The recommendations in terms of the screening modalities are listed here on the right. In 2011, the American Cancer Society, the American Society for Colposcopy and Cervical Pathology, and the American Society for Clinical Pathology updated their joint guidelines for cervical cancer screening, as did the U.S. Preventative Services Task Force. Subsequently, in 2015, the ASCCP and the Society for Gynecologic Oncology issued interim guidance for the appropriate use of an HPV co-test for primary screening for cervical cancer that was then approved by the FDA in 2016. The cervical screening recommendations in this table are the joint recommendations for the ASC, the ASCCP, and the ASCP, which are based on a review of the highest quality scientific evidence. In general, what the key takeaway messages from this slide are that cervical cancer screening should begin at age 21 years. With the exception of women who are infected with HIV, women younger than 21 years should not be screened, regardless of their age at sexual initiation or the presence of other behaviorally related risk factors. This is certainly a change from what many of us who are older physicians may have learned during our training. Women between the ages of 21 and 29 should be tested with cervical cytology alone without the use of HPV co-testing, and screening should be performed every 3 years. Annual screening should not be performed for women in this age group. For women who are ages 30 to 65 years, co-testing with cytology and HPV testing should occur every 5 years. Screening with cytology alone every 3 years is also acceptable. Again, annual screening should not be performed. Screening by any modality should be discontinued after the age of 65 in women with evidence of adequate negative prior screening test results and no history of cervical intraepithelial neoplasia or CIN2 or higher. What exactly does this mean? An adequate negative prior screening test result is defined as having had 3 consecutive negative cytology results or 2 consecutive negative co-test results within the previous 10 years, with the most recent test performed within the last 5 years. For women who have had a total hysterectomy, or which includes removal of the cervix, and have never had CIN2 or higher, routine cytology screening and HPV testing should be discontinued and should not be restarted for any reason. For women who have been vaccinated against HPV, clinicians should follow the age-specific recommendations, which are listed at the top of this table. What's the rationale for the HPV co-testing guidelines? Essentially, HPV testing stratifies women for risk based on their risk of progression to cancer. It allows for less frequent screening due to the high sensitivity of the HPV test. The rationale is that a normal Pap and a negative HPV test give a high assurance that cervical cancer is not present and is not likely to occur in the next few years. In fact, when both tests are negative, the 5-year risk of CIN3 is 0.16%, and the 5-year risk of cancer is 0.016%. The other rationale for HPV co-testing is that it helps to identify women who may need increased surveillance. A positive HPV and a normal Pap test reflect an increased risk for either missed disease or the subsequent development of CIN2 or 3 and cancer. Again, HPV testing is not appropriate for women in these situations. It is not appropriate as a screening test, a general screening test for sexually transmitted infection. It's not appropriate to determine the HPV status before vaccination or to triage women with Pap results other than ASCUS, with the exception of postmenopausal women who have a low-grade squamous interepithelial lesion, or LSIL. It's also not appropriate as an adjunct to Pap testing and primary screening of women who are less than 30 years of age, because HPV in that age group is highly prevalent, while the prevalence of both concurrent cervical cancer or the subsequent development of cervical cancer is extremely low. HPV co-testing or testing in general is also not available for women who've had a total hysterectomy for benign disease. What about HPV vaccine guidelines? These too have changed over the course of the last 10 years since the vaccine became available. This slide shows the updated HPV vaccination recommendations of ACIP, which recommends routine vaccination for all adolescents beginning at the age of 11 or 12. This recommendation is based on the fact that individuals in this age group have the highest immune response to the vaccine. It's also based on the fact that ideally you want to vaccinate adolescents prior to sexual initiation. HPV vaccination is also recommended for females ages 13 to 26 years and for males ages 13 to 21 years if they were not adequately vaccinated when they were younger. Males ages 22 through 26 may also be vaccinated. Some special circumstances are in the second box below. For children with a history of sexual abuse, routine HPV vaccination should begin at the age of 9. For men who have sex with men, routine vaccination should proceed as indicated in the box at the top, as for all males, and vaccination should be available up through the age of 26. For transgender persons, routine vaccination should occur as indicated for all adolescents and for individuals up through the age of 26 who have otherwise not previously been adequately vaccinated. For individuals with a primary or secondary immune compromising condition, vaccination with 3 doses of the HPV vaccine is recommended for those between the ages of 9 and 26. This slide details the recommended number of doses and intervals for HPV vaccine by age and by the series of initiation and medical condition. For persons initiating vaccination before their 15th birthday, the recommended immunization schedule is 2 doses of the HPV vaccine as shown in the first row. The second dose should be administered 6 to 12 months after the first dose. In a 2-dose schedule, the minimum interval between the first and second dose is 5 months. For persons initiating the vaccination on or after their 15th birthday, the recommended immunization schedule is 3 doses of the HPV vaccine. The second dose should be administered 1 to 2 months after the first dose, and the series should be vaccination at 0, 1 to 2 months later, and then at 6 months. In a 3-dose schedule of the HPV vaccine, the minimum intervals are 4 weeks between the first and second doses and 12 weeks between the second and third doses, and 5 months between the first and the third dose. I'm not going to walk you through this entire algorithm step by step, but this is provided in your slide deck as an algorithm that can help you determine what's the most appropriate course of action for an individual patient who you may be seeing. This algorithm or decision tree was published by the Centers for Disease Control. This is a duplicate of the slide we looked at earlier, and is a reminder that we're now going to transition to looking at issues of race, ethnicity, and sexual minority status, and how that differs in terms of risk and service delivery for different individuals. So what about race and ethnic disparities in HPV infection and vaccination status? Greater proportions of Black and Latino men and women are diagnosed with HPV-related cancers and tend to be diagnosed at later stages of the disease than both men and women of other races or ethnicities. There continue to be racial and ethnic disparities in the uptake of the HPV vaccine. While Black and Latina adolescent females have similar or even higher rates of initiating the HPV vaccine than their white counterparts, studies show that Black females are less likely to complete the series compared to white adolescent women. And although this talk is focused on females, a study called the Cognitive and Emotional Responses to HPV in Men, or the SEERS study, which surveyed men who had been tested for genital HPV, explored some of the racial and ethnic differences and factors associated with HPV vaccine intentions among males. And these data provide potentially some insights into disparities that may be relevant for racial minority females as well. This study found that non-Latino Black respondents were less knowledgeable about HPV infection than were men in other groups, despite being repeatedly educated about HPV. Non-Latino Black men were the least likely to identify barriers to vaccination, such as costs and side effects, and were the group that seemed the least likely to actually be vaccinated. These data are important when we look at the incidence rates for cervical cancer, which are shown on the current slide, as well as when we look at mortality rates related to cancer, which I'll show you on the next slide. This slide shows incidence rates between 1999 and 2013 on our x-axis, and the y-axis shows the rates per 100,000 individuals. Races are listed according to different colored bars, and what you can see is that rates among Black and Hispanic individuals for cervical cancer were much higher than among other individuals. The black line here is the line showing all races. If we look at the subsequent slide, which focuses on mortality rates, we see a similar pattern where both Blacks and Hispanics have higher rates compared to other racial groups that are significantly above the incidence line for all different races. What if we look at what's happening with HPV infections and vaccination status and screening rates in sexual and gender minority populations? HPV is the most important and prevalent risk factor for cervical cancer, as we've discussed, And while sexual minority women are at risk for infection with HPV, relatively little is still known about the prevalence of HPV infection in this population. Data analyzed from the NHANES study from 2003 through 2012 among women between the ages of 20 and 58 examined sexual orientation and HPV outcomes. And what this found was that HPV infection was more common among non-heterosexual women compared to heterosexual women. When looking at individuals with any type of HPV infection, they were 49.7% prevalence of HPV infection among non-heterosexual women compared to 41% among heterosexual women. When only high-risk HPV types were examined, almost 40% of non-heterosexual women had a high-risk HPV infection, while only 27.9% of heterosexual women did. Estimates using data from approximately 80,000 women who participated in the California Health Interview Survey showed that the cervical cancer prevalence was higher among bisexual and lesbian women compared to heterosexual women. The prevalence among bisexual women was 41%, among lesbian women was 17%, and among heterosexual women was 14%. Moreover, a survey using data from the 2006 through 2010 National Survey of Family Growth, which examined the association between sexual orientation identity and HPV vaccination status among women and girls, also found disparities. The survey used stratified cluster sampling to establish a national probability sample among women and girls between the ages of 15 and 44. Among this population, 84% reported having heard of the HPV vaccine. After adjusting for covariates, only about 9% of lesbian women reported having heard of the vaccine, compared to approximately 30% of their heterosexual counterparts. When our next slide comes up, we'll be looking at cervical cancer screening rates among sexual minority women. Can someone please help advance our slide? Thank you. Sexual minority women are often screened at lower rates than their heterosexual counterparts. And this is unfortunate since HPV has been detected in somewhere between 15 and 30% of sexual minority women, including women who report having never had a male sexual partner. This highlights that knowing the sexual history of one's partner is critically important, and that for an individual woman, not having had sex herself with a male partner may not totally take her risk of HPV infection away. Precancerous cervical lesions have also been detected in sexual minority women who report having had no previous sexual contact with men. Thus, routine cervical cancer screening should be offered to all women, regardless of their sexual orientation. These last few slides really highlight the fact that inclusive strategies for client-centered care are really important. It's important to ask for and use each client's preferred name, pronouns, and anatomical terms, to collect a gender-neutral sexual history and provide relevant sexual health counseling, regardless of sexual orientation. It's important that we offer cancer screening in relation to anatomical organ and risk, rather than based on an individual's sex at birth or gender. It's important that we ask clients questions to guide the visit. For example, do they prefer more or less detail in explanation of having a speculum exam performed, as some patients may have little experience with this, and providing that anticipatory guidance may be both helpful in establishing a respectful relationship, but may also reduce patient anxiety regarding having such a procedure performed. It's also important that we request and follow client guidance for minimizing any emotional and physical discomfort and for supporting their internalized locus of control throughout our encounters. And really, these counseling points that are really designed to help us with managing our sexual minority patients in a very respectful and client-centered way also really highlight the importance of taking a comprehensive and routine sexual history from patients, which these next two slides will highlight. Taking a routine sexual history is an essential part of a patient's comprehensive history. It can also be part of a focused history in other clinical circumstances, such as when individuals are presenting with acute urogenital complaints, particularly for a sexually transmitted infection. Learning about the sexual health and behavior of patients is an important part of providing patient-centered, efficient health care and should be taken from all adults and adolescents, regardless of gender identity, orientation, or sexual practices. It's important to note that this may sometimes mean asking respectfully that any individuals who accompany an individual to their visit leave the room so that confidentiality can be ensured. The sexual history gives opportunities also to educate and counsel patients about a full range of sexual and reproductive health issues, including sexually transmitted infections, and allows healthcare providers to connect patients to treatment and appropriate care when indicated. Without taking a sexual history, it's difficult to know what risks the patients may be facing and what tests, exams, or vaccinations are needed. Without this information, the opportunity for prevention is missed, and existing diseases or conditions may be allowed to progress to a more serious state before they are diagnosed. This slide shows an algorithm for conducting a sexual history. The sexual history can come up naturally when talking with a patient as part of the social history. It can also be asked in relation to the patient's past medical history or history of reproductive health. Before starting, you should let the patient know that you ask the sexual history of all your patients as part of their routine care. If the patient declines to complete a sexual history, consider asking if there's another member of the clinical care team with whom they might feel more comfortable. This may be the nurse or another clinical provider who they may have seen in the past. There are 3 screening questions that are shown here that really provide a starting point for the initial intake. And those are shown and indicated with these numbers. It's important when asking these to maintain neutral language and to not make any assumptions about an individual's sexual behaviors or preferences. For example, women who identify as lesbian may have had or continue to have sexual relations with men. So these 3 questions, the first one is really designed to set the stage for the sexual history taking. And so this is really just letting someone know what questions you'll be asking and that you will ensure their confidentiality. You want to ask, have you been sexually active in the last year? Do you have sex with men, women, or both? And how many people have you had sex with in the past year? You can then determine if the patient needs a more detailed risk assessment according to whether they've had, for example, multiple partners or a new partner, if they're in a long-term monogamous relationship, or if they're not sexually active at all. All patients, regardless of sexual history, should also be asked whether or not they have any concerns about keeping themselves sexually safe and healthy. Although the 3 questions presented here are brief, it's important for healthcare providers to recognize that a sexual history will, in some situations, lead to a longer discussion of important health and related issues. This slide is really designed to highlight some additional key questions that can be asked as part of taking a comprehensive sexual history, and whether or not you go into each of these different areas will really depend on the responses to the 3 questions reviewed on the prior slide. The Centers for Disease Control and Prevention developed this simple categorization of sexual history questions that healthcare providers can easily remember, which is referred to as the, quote, 5 Ps. It is a way to ask about partners, practices or substances that an individual may use, alcohol or illicit drugs that can impair judgment, any past history of sexually transmitted infections, an individual's use of protection from sexually transmitted infections, such as condoms or dental dams, and what their pregnancy plans are. So let's return to our case from the beginning, the case of Janelle, a 19-year-old Caucasian female who presents for the first visit to a university clinic for women's health, who's interested in switching from oral contraceptives to an intrauterine device. Her medical history, as I mentioned at the beginning of this talk, was unremarkable, and she was unsure whether she had had the HPV vaccine. So 3 questions were posed. What are some of the critical questions that you might ask as part of her medical and sexual history? These, remember, include whether or not she's been sexually active in the past year, how many partners she's had in her lifetime, and how many in the last year. This patient tells you that she has been previously sexually active. She began having sex at the age of 16. She's had 4 partners in the past in her life, and she's had 1 partner in the last year. Her partners are generally male only. You ask if she's used protection against sexually transmitted infections, and she tells you her boyfriend uses condoms about half the time. This is certainly an opportunity to advise and counsel her about her risk for sexually transmitted infections and the importance of using condoms for STI protection. It's also an opportunity for you to provide an affirmation to her for engaging in pregnancy prevention behaviors by using contraception, as well as a reminder that condoms, more consistent use of condoms, can help with STI prevention. With regards to her HPV vaccine, on further questioning, she thinks she received at least 1 dose of the HPV vaccine as an adolescent. So how could you proceed with clarifying her vaccination status? You could certainly ask more probing questions or get a medical record release to get records from her prior care providers. Hopefully you'll be able to clarify with her whether her first dose of the vaccine, if provided, had occurred before the age of 15 or not. And then as highlighted in one of our earlier slides, what you do from there depends on the information you're able to gather. If she's never been vaccinated and she's over the age of 15, she would need to initiate her HPV vaccination series, and she would need to receive 3 doses of the HPV vaccine, 1 today, another in 1 to 2 months, and her 3rd dose 6 months later. If she was previously vaccinated with her first dose prior to the age of 15, she could simply receive 1 dose of vaccine today. If her prior dose was after the age of 15, she would need to complete a 3-dose series, meaning she would need 2 additional doses. It's important to mention that the type of HPV vaccine that was used with her first vaccination dose is not important. She can complete her HPV vaccine series with, for example, the 9-valent vaccine that's currently available. What are the key takeaway messages for today? That HPV vaccine is the most common sexually transmitted infection in the U.S., affecting nearly all sexually active individuals at some time. The most common cancers attributable to HPV are cervical, anal, vaginal, and oropharyngeal. Of the approximately 31,000 cancers attributable to HPV, the vast majority are preventable with the 9-valent HPV vaccine. A sexual history should be taken from all adults and adolescents regardless of gender identity, orientation, or sexual practices. And it's important for healthcare providers to view HPV through the lens of intersectionality by thinking of issues regarding gender, race, ethnicity, as well as gender and sexual identity and individual socioeconomic status. We focus today on race, ethnicity, and sexual identity only, but certainly thinking about differences in screening rates and knowledge, healthcare access and service delivery with regards to these other social domains is important. We've listed here some additional resources that you can use for additional learning. And here are our upcoming webinars on HPV. There will be one on HPV in special populations, gender and sexual minorities, which will be held on November 16th. There will also be an HPV frequently asked questions roundtable on Tuesday, November 21st. You can sign up for these additional webinars at the website listed here. And with that, I'm happy to take any questions.
Thank you, Dr. Akers, for that very informative presentation. We will now take questions. I have one question. If a full sexual history cannot be taken, what are the most important details a provider should know?
I think the most important details are really these 3 questions that were outlined on our slides previously. Can I go back? Whether an individual has been recently sexually active will certainly provide key information that you can use to guide, for example, making decisions about recommending additional STD testing that day. Whether or not an individual, what types of individuals someone has sexual intercourse with can also aid with risk stratification and making additional recommendations. And then the number of recent sexual partners can also provide a lot of guidance. When I trained, there was a much longer sexual history that was recommended. These 3 questions have really been identified as the main ones that can really help you with risk stratification and subsequent guidance for your patients. I oftentimes, because I manage adolescents, may have a limited amount of time confidentially with my adolescents, and I find that these questions and my subsequent counseling for my adolescents after them can oftentimes be done in a very brief amount of time, allowing them confidentiality but also access to critical care services. That's a great question. Thank you.
Next question, your slide mentioned routine vaccinations. How often does the HPV vaccine need to be re-administered after dose completion?
That's a great question. We're hoping that there will be some additional information and guidance coming out in the next couple of years regarding this, but at present, there are no recommendations for additional boosters after someone has fully completed their vaccination series. So either after they've completed the 2-shot or the 3-shot series based on current guidelines.
Okay. Next question, what accounts for the sudden rise in HPV infections in all women in the late 2000s versus other women?
Sorry, can you say that again? What accounted for the rapid rise?
What accounts for the sudden rise in HPV infections in Asian and Pacific Islander women in the late 2000s versus other women?
That's a great question. So I'm not entirely sure which studies you may be pointing to, but I know that there have been other sexually transmitted infections, particularly chlamydia, in the mid to late 80s and early 90s, where the incidence appeared to rise. And that was found to be due not so much to a significant change in the true incidence or prevalence, but rather to improvements in screening practices and therefore case identification. So my guess is that is likely what's happened with Asian and Pacific Islander women, is those populations have traditionally had much lower rates of screening and later ages at diagnosis of either cervical changes, abnormal cervical cytology, or cervical cancer.
And the last question, why is it that the mortality rates are highest for Black women, and what implications can be done to influence the high mortality rate?
That is also a great question. So much of the it's a great question because we do know that the screening rates, depending on the study, screening rates have either been found to be similar or only slightly lower. However, follow-through after identification of abnormal precancerous pathology is much higher among, is much lower among Black women. And so the problem is that Black women are much less likely to follow through with recommended subsequent care for an identified pathology, which means that those who then go on to progress to cancer are showing up at later stages of the disease and therefore have higher mortality rates. So what does that mean in terms of interventions that can address these disparities? One is patient education, certainly trying to counsel women and make sure they're appropriately informed and educated. I think another approach that is increasingly being used is really helping to reduce anxiety about follow-through with care. So oftentimes women may express a lot of fear about receiving bad news that may lead to them not coming in, and really clarifying that the reason for follow-up is really to prevent cancer and to give them the best chance at life. Many interventions have been developed, but making a change in this area has really been slow to come. So if anyone is interested in that area of work, certainly it's an area in which we need a lot more effective interventions.
Okay, we received a lot of questions. However, I only have time for about 2 more. So next question. I am a forensic nurse and see victims of sexual assault. We provide PEP, but should we be recommending HPV vaccination, and in what age group?
So the only time sexual assault kind of appears in our guidelines for HPV vaccine is really in individuals who were sexually assaulted at an early age. It's recommended that they initiate the HPV vaccine at age 9 as opposed to age 11. What I would say is that for the patients that you're seeing, depending on their age, assessing whether or not they have already completed their vaccination series or if they've started it, where they are in their vaccination, in the vaccination series, and making sure that they are able to complete that series is important. If someone has never had the vaccine and they are within the 9 to 26-year-old age group, it's also important to let them know that even though they may have already had sex, whether it was consensual or not, the HPV vaccine can still be helpful because usually a single act of sexual intercourse will not expose someone to all of the potential HPV types. And so there can certainly be tremendous benefit in receiving the vaccine even after sexual initiation.
And why is there an increased risk of HPV positive in women over age 30 in long-term monogamous relationships?
So I'm not entirely sure where that question is coming from. However, I will say that what has been noted is that there appears to be a bimodal distribution of the HPV infection. So we tend to see that it is the prevalence is very high among women under the age of 25, but there does appear to be sort of a second epidemic, so to speak, in women that are in the midlife phase, so actually a little later than the age in the question. And it's believed that that second bump that we see is actually women whose partners may have passed away or they've gotten divorced and they're acquiring new partners and are therefore being exposed or re-exposed. In terms of, you know, variations in prevalence otherwise across the ages, reality is that women can be exposed throughout their sexual life course. And sometimes you might be with a partner for a while before actually acquiring an infection. And so each act of sexual intercourse confers a small risk of infection, which means that it is possible that you could be in a monogamous relationship with someone but not actually manifest an infection until sometime down the line.
Thank you, everyone, for the questions that you asked. If you do have additional questions or the ones that we did not get to, please email us at education@arhp.org. Thanks again, Dr. Akers, for joining us today. Before you exit this webinar, please note the following. Be sure to visit arhp.org to view 2 clinical minutes and register for the second and third webinars in this series, which will be Thursday, November 16th at 4:30 p.m. on increasing vaccine uptake, and Tuesday, November 21st at 12:30 p.m. on frequently asked questions. As a reminder, you will soon receive an email from ARHP's Education Department containing a link to the post-test survey. Your CME or CE certificate will be generated at the end of the survey. Be sure to print the certificate before closing the internet browser